So another, we can start. Huh? So we'll now look at
Yes, okay, start.
hemorrhagic diseases of the newborn. Okay. So this is just a next
There's someone who is making noise.
a small page. Huh? So hemorrhagic disease of the newborn. Okay. It's a disorder that occurs in the early period of the what? Postpartum period of the infants. And this comes in as a
Okay.
result of a deficiency of vitamin K.
They make it.
Okay? So these babies, there is a deficiency in vitamin K. Okay? And also which is depending on other protein factors. Protein factor 2, protein factor 7, protein factor 9, and the protein factor.
Sir, unmute your mic. Sir, Mr. Mwanza, your mic is muted. We can't get you.
Are you there?
Yes, sir.
What I was saying is that we would define hemorrhagic disease as a disorder that occurs in the early what? Postpartum period after these babies are born. Mostly it comes in as a result of deficiency of vitamin K and also dependent protein factors like protein factor 10, protein factor 2, protein factor 9, and the protein factor 7. When you talk about the incidence, we're just looking at the prevalence. So most you find that people or these infants that will have these hemorrhagic diseases, there are those that are prematurely born. Also, those babies that don't receive vitamin K at what? At birth. Okay? So also we should know that those infants that are started on what? Um, those infants that are started on these other feeds at birth, that high risk of doing what? Developing what? Vitamin K. Okay? Those infants that are started on these other foods, that high risk of developing hemorrhagic disease, because in breast milk there's also what? There is the presence of vitamin K. So if these infants, they are after being born, they have been started on other foods, they have a high risk of developing hemorrhagic diseases.
Okay.
Let us look at the classic causes. Okay? So, what happens is that sometimes during when these infants are still in the mother's womb or in the amniotic sac, there is a depletion of transplacental vitamin K. Okay? That happens. But this mostly happens on the second day after birth. So this infant has been born. After they have been born, what happens is that there will be depletion of the vitamin K, okay, through the placenta. As a result of these vitamin K deficiencies that has come in, you will find that these infants are now presenting with what? Signs and symptoms of hemorrhagic what? Condition. Okay? Also, it may also come as a result of delayed endogenous what? Vitamin K synthesis on the what? 7th day. Okay? Which is mostly coming as a result of lack of intestinal what? Bacterial flora that is supposed to form in the what? In the intestines. Also, what you remember that on the causes I said the prematurity plays another role. So when you look at prematurity, you may marry it now where we talk about it. Most of the organs haven't been fully formed in this infant. This is where now you find that there will be things like liver immaturity in the what? In the infants. So let us look at the early onset of hemorrhagic disease. So you find that when this infant has been born, on the first day of life, these infants will start presenting with what? Signs of symptoms of, or when you look at their body skins, you find that there will be those hemorrhages that are on the upper part of the skin that are doing what? That are forming. Okay? Also, you may find that on the first day they may be present due to what? To maternal medications during pregnancy, which will inhibit what? Neonatal vitamin K what? Production. So we may give an example of phenobarbital, also an pentoin. The late onset of hemorrhagic disease, this may present in the what? The 2nd to 6 months period. Okay? This now will come in not because that or because of the transplacental depression, but this now it will come in as a result of what? Malabsorption of vitamin K by the what? The baby's body. Okay? So, and an example which will come in, it is mostly due to what? Cholestasis. Okay? So, what is the clinical picture of the presentation? So, the questions that I must ask is to say, when does the hemorrhagic disease do what? Present. Remember I said that there is early onset that you may present on the first day after what? After the infant is born, but also it may also proceed to periods that go as far as 7 months. But it is important for you to understand the sites where these hemorrhagic diseases are doing what? They are occurring from. Okay? So when? Usually they present on the 2nd to the 7th day of life. Okay? So there can be a representation of this hemorrhagic condition, or there can be the late presentation. Okay? When you look at the sites now, you may find that these sites on the GIT, gastrointestinal, also they may be present on the what? On the umbilical. Okay? In circumcision site, they are rarely on the what? Internal what? Hemorrhages. But also there's a high chance that they may also be present what? In internal. Okay? What you look for. Okay? So when you look at this baby will look what? They will look healthy. Okay? In cases, except in severe hemorrhagic or intracranial hemorrhages, whereby you may find it hard to do what? To notice the what? The hemorrhage. Okay? But also, if there are what? Internal intracranial hemorrhage, what will nicely make you know that there is a hemorrhagic condition is that there will be hemorrhagic anemia. Okay? There will be this. There will also be in this para. They will be present with tachycardia, but this tachycardia will read about what? To shock. And you know that in these now, when there is this shock and these are still infants, it's high time for us to do what? To suspect hemorrhagic diseases. Okay. So what investigation are you going to do for you to really make a diagnosis to say we are dealing with hemorrhagic conditions of these infants? We'll do what we call as the prolonged prothrombin time, PT. Okay? Also, we can also do what we call as a partial thromboplastin time, which is PTTT. Okay? We can also look at investigations of deficiency of vitamin K dependent factors that we may look at. We may also look at, it is important to look at, when you do a full blood count also, to look at the platelets of this what? Of this infant. How do you, the management is very simple. We know that this infant is lacking what? Vitamin K. So, we give vitamin K 1 gram IM at birth. Okay? We can also, if there is a history of maternal convulsion, because it is possible that there may be preeclampsia and eclampsia. I said these conditions, you nicely understand them when you do obstetrics, okay? Where we look at preeclampsia and eclampsia. But if we've taken a good detailed history, and we know that there is a history of what? Maternal convulsion in these infants. Instead of, we can still give vitamin K in between 1 to 2 milligrams or IV. Okay? So we remember that I said on the investigation you can do the PTTT, you can do the PT. Also, we do the full blood count. We know that these patients, in case it's intracranial hemorrhage, what will be present is that these patients will present with the pallor and tachycardia, which will lead about to shock. So what we do is we give fresh plasma transfusion. Okay. In case, remember that sometimes because of the prematurity, they may have issues with the liver, but in these patients with the, who may present with liver diseases, we will give them fresh plasma transfusion for those preterm babies and those with liver disease. Okay? So in case there will be severe bleeding that is present, the severe bleeding, what we do also is that we give fresh blood transfusion, the whole blood, that we also administer to these infants. Okay, so we'll look at another common hemorrhagic disease of the newborn, which is neonatal polycythemia. Okay, so we'll define neonatal polycythemia as an increased red blood cell count with venous hematocrit value over what? 65%. By this time, I assume that you guys are very conversant and confident when you look at the hemogram, which is done in medicine. So, neonatal polycythemia is an increased red blood cell count with venous hematocrit value that is greater than what? 65%. What are the causes of neonatal polycythemia? Okay, so this neonatal polycythemia may come in as a result of placental red cell transfusion. Okay, so we know that when we go into obstetrics and gynecology, there is in labor, to be specific, there's what we call as the third stage of labor, where there is the management of third stage of labor, where we have to clamp the placenta of this infant. So, if there is a delay in the clamping of the placenta of this baby, this will also increase the chances of this infant developing polycythemia. Also, another etiology, or which is the cause, is placental